Are we good to go now? Shall we start the program, ma'am?
Yeah, go on.
Okay. So I request the attention of the faculties and the delegates. I will take a few minutes of yours and let me introduce me and introduce the faculty members of the session. Good evening and welcome to one and all. I'm Ankita from Planet, the designated session assistant for a seamless experience. And Planet is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Society of Onco-Anesthesia and Perioperative Care. And the topic of today's session is HIPEC. So let's begin today's session, for which I would like to invite Dr. Anjali ma'am to take over. So over to you, ma'am.
Good evening, everybody. Thank you for joining us. Today, we're going to discuss HIPEC. Dr. Sohan Solanki, as you all know, is our secretary, and he has initiated the guidelines, Indian guidelines for HIPEC. He's going to speak to us. And to chair this session, we are lucky to have Dr. J.D. Devatia with us. He has many accomplishments to his name, so I cannot mention all of them, but you already know him well because he's a mentor to nearly all of us over here. He is professor and head Department of Anaesthesiology, Critical Care and Pain, Tata Memorial Hospital, Mumbai. And he's also a past president and also the past president of ISCCM. He's the president-elect of ISA and the editor-in-chief or the past editor-in-chief of IJA. Over to you, sir.
So good evening. Welcome to this webinar today on HIPEC. And the HIPEC is probably one of the few procedures which are exclusively in the domain of onco anesthesia and onco surgery. Because it doesn't happen in any other sort of specialty. So this is a very unique procedure, and it's also a very intense procedure. It's a very demanding and challenging procedure, and we are very fortunate that we have Dr. Sohan Solanki with us. He has got extensive experience in HIPEC. He's in Tata Memorial Hospital. He's part of the group which virtually does almost all the HIPECs that go on in the hospital. And not only has he got experience, he's also dynamic changes and many other aspects of outcomes of HIPEC. So I think we are fortunate that Dr. Sohan Solanki will be speaking to us. And I think let's hand over to Dr. Sohan so he can share his expertise and his views and experience on the manual of HIPEC. And I suppose he'll speak on some of the other variants of HIPEC, which are sort of also some of the variant procedures of HIPEC. Dr. Sohan.
Thank you, sir. So I will share my screen. So good evening. My screen is visible, right?
Yes, sir, it's visible, sir.
Okay. So thank you very much, sir, for the introduction. And this today's talk is like with this perioperative management of CRS HIPEC. So I will cover what is like this HIPEC, what is CRS, and how we manage this procedure perioperatively, and what are the complications associated with this procedure. So this CRS, also called this cytoreductive surgery, is the reduction of the disease or the cancer load from the body, and it mainly refers to the abdominal pelvic cancer. In some cases, it may also like with the thoracic, but mainly the abdominal cancers. So the disease is mainly a primary peritoneal disease or a peritoneal cancer from the GI or the gynec cancers. And traditionally, these diseases were considered incurable and having a poor prognosis traditionally. But Dr. Paul Sugarbaker showed that a surgical removal of the visible tumor combined with the heated chemotherapy can actually improve the survival and the quality of life in this patient. So after that, this CRS and HIPEC procedure became the standard of care for this type of cancers. So, and this procedure is complex surgery, and it's having so many complications intra or post-operative. So the outcome mainly depend on the this what the health of the patient, how much is the disease in the abdomen, what are the surgical factors, what are the different intraoperative events, and like how you are managing intraoperative like events, and what chemotherapy drugs you are giving for the HIPEC. So why we do CRS? Because this peritoneum can be resected completely from the body, and all the this macroscopic disease can be resected from the abdomen. And these cancer, they don't metastasize generally outside the abdomen. Why and why HIPEC and what is HIPEC? So in HIPEC, we give a high dose of intraperitoneal chemotherapy directly into the abdomen after the surgery or after the CRS procedure, because at that time the surface is raw and it has a better penetration into the tissue. And why heated? Because the heat and the chemotherapy, they have a synergistic effect on the cancer cell, so they can combinedly they can like kill cancer cells better. If we talk about the what different chemotherapy we give, so mostly they give either carboplatin, cisplatin, mitomycin C, or oxaliplatin, because these drugs, they have a heat synergy also, and also they have a good penetration into the surface after the CRS procedure. And the most important thing is that these chemotherapy, they are not they are non-cell cycle specific. It means they can kill the cancer cell at any cell cycle. Also, they have a good like intraperitoneal to the intravenous ratio. Some chemotherapy drugs like paclitaxel and this 5-FU given in some gynec cancers, they although they don't have any heat synergy, and they have a penetration also reasonably good. And the other problem is they are cell cycle specific. If the so if the cancer cell is not in particular cell cycle, they will not be able to kill the cell cycle. But the best part is that they have a very high intraperitoneal to the intravenous ratio. That's why these are all also used in some of the cancers. For like what patient we normally select, patients should be either a primary peritoneal cancer patients or a METS from the GI or gynec cancer. The disease generally should not be from outside the abdomen, and the patient should have a good physical and a performance status. So you have to select the patient accordingly to do this big procedure. So about the peri-op management, so like in a SOPSI, we like came out with this first international guideline on this CRS HIPEC. We included like many centers in India and like few centers from abroad also. And we came out with the complete perioperative protocol and the management strategy for the CRS HIPEC procedure. And so if we talk about the pre-op assessment and the pre-op optimization of these patients, so counseling is very important in this patient, because this disease and this procedure is very lengthy procedure, very morbid procedure. So the complete counseling about the like hospital stay outcome, we should be telling to the patient and the family. Also, these patients should be evaluated by a concerned and a specialist anesthetist beforehand. Also, all recent lab investigation must be done before the surgery. And normally we advise this 2D econ all these patients, because these patients like they undergo large fluid shift, and there are need of large fluid and very large quantity of fluid in the during intra period. Also, we must optimize patient for any nutritional deficiency or anemia, like we to correct some anemia also. So also give some physical exercise. A chest physiotherapy is must. So a prehabilitation part is very important to have a good outcome in these type of surgeries. If you talk about the what type of like during stages of surgery, so there are mainly 3 stages. First stage is called the CRS or the cytotoxic surgery, where we decrease the burden of the disease from the abdomen, and the second part is HIPEC, this hyperthermic intraperitoneal chemotherapy for around 90 minutes, but it may range from like 1 hour to 2 hours. And the temperature is normally between 41 to 43-degree temperature, and they need a specialized type of pump and a perfusionist who runs the pump. And in the reconstruction phase, the bowel is anastomosis, and then we'll close the abdomen. The patient is shifted to the recovery room or the ICU. So this is a very good this graphical diagram of this like different stages. So you see that this is after the induction, we have the CRS phase and the HIPEC phase and the reconstruction phase. And in this HIPEC phase is arbitrarily divided into the H1, H2, and H3, and there's even H0 phase, like around half an hour to 1 hour prior to the HIPEC. And in this phase, we actually prepare the patient for the HIPEC. And in HIPEC, if you see the temperature trend, then temperature rise very rapidly from the start of HIPEC to up to H1 phase. And from H1 phase to H2 phase, the temperature rise slowly. And from H2 phase, it becomes a plateau. And then comes this reconstruction phase after H3 phase, where like all this warm fluid is removed from the body, and we close the abdomen and accept the patient to the recovery. If you talk about the how bad is the disease, or like what is the PCI, it's called the peritoneal cancer index or the peritoneal carcinomatous index. So so Dr. Paul Sugarbaker divided the abdomen into the 9 equal quadrants and 4 areas into the small intestine. And so there are 9 plus 4 equal to 13 areas of the disease he divided, and in each area the score of either 0, 1, 2, and 3 is given. If there is no disease or no some seeding anywhere into that area, the score is 0. If the disease of up to 0.5 centimeter is there, then its score is 1 is given. If the disease between 0.5 to 5 centimeter, then it's called the score is 2. And if the disease is more than 5 centimeter, that's called the score of 3. So the maximum score is 39 and the minimum score is 0. So PCI cannot be more than 39 in any patient with the any amount of disease in the abdomen. How good is the disease? It is like calculated by the CC score. It is called the completion of the cytoreduction scoring, and it is the mainly the surgeon's work. How good is the surgery? It will tell you the and so it will be can be told by the CC scoring. So CC 0 when there is a complete removal of the cancer from the abdomen before HIPEC, and CC 1 is when up to 2.5 millimeter diameter disease is still present in the abdomen. So if the CC 0 is considered the best surgery, CC 1 also is a good surgery. But if your CC score is 2 or 3, when your disease is more than 2.5 millimeter under the abdomen, then the patient will have a bad prognosis, and there's really no benefit of giving HIPEC after this type of surgery. If you talk about the ERAS, because nowadays ERAS is like people are doing every type of surgery. So the HIPEC is also this ERAS protocol is not very well established for the HIPEC because of the long duration surgery, large fluid shift, and everything in long stay. So this European Society of Oncology, they came with a ERAS guideline for the CRS HIPEC surgery part 1 and part 2. In the part 1, they describe the preoperative and intraoperative management. In the part 2, they describe the postoperative management of the ERAS. You can go with this article if you are interested. And in India, we actually came out with some of the guidelines after a survey nationwide. So we are also into that process of developing the ERAS guideline for the CRS HIPEC. So how we manage these patients intraoperatively? So intraoperatively, we give the standard general anesthesia with epidural. If the epidural is not contraindicated, we can give inhalational or TIVA, whatever your choice. There is no clear-cut benefit of TIVA over inhalational. And even in one retrospective study from the MD Anderson, they said that this inhalational anesthesia was better for HIPEC, but there was no clear-cut evidences, I can say. In the monitoring, so the standard ISA monitoring we should do. The invasive BP is required. Core body temperature must, because the patient have a large temperature fluctuation. So esophageal or nasopharyngeal temperature probe is required. Cardiovascular monitoring you can use based on the disease status and what if a patient having any cardiac problem and all these things. CP monitoring, you can monitor CP, but in most cases we require a central line, so you can also measure CP, but it's not mandatory. Blood gas we normally do because the patient may go into some of the acidosis and everything. So blood gas we measure. The lactate we measure because the patient may go into the hyperlactatemia, especially during the HIPEC phase, because of hyperthermia the patient lactate increases. And in the intra period, we in the CRS phase, we always give this fluid warmer and the warming blanket to the patients. About the hemodynamic therapy, so we should measure this cardiac monitoring or hemodynamic monitoring if the patient having a very large volume of disease, means with high PCI, the patient is having this bad cardiopulmonary comorbidities, And if the patient, if we are expecting a major fluid and the blood loss, so in that case, your cardiac monitoring will help you always. The fluid therapy can be a goal directed, and your goal can all be either SVV or a pulse PPV or the stroke volume or the delta stroke volume or lactates you can also measure. This balanced salt solution is always better than the normal line. And if you want to use colloid, albumin is it's supposed to be the best colloid for these patients. And we also do the intraoperative investigation to know the hemoglobin and the coagulation. And normally we do after like your CRS phase. So when your blood loss is over, then you can see all this coagulation and hemoglobin. So this is like my hospital, like HIPEC OT, where we use this cardiac monitoring, and it's the HIPEC machine. So we use CVP also, with Heartline also, like all these things cardiac also. This is the HIPEC procedure doing HIPEC. So hemodynamic management. So in the CRS space, this hemodynamic management is based on like the blood loss and the fluid loss. With gold active fluid therapy, it is actually same as any other major abdominal surgery. In the HIPEC phase, where this large cold fluid is required to keep the temperature in control. In that case, in that time, your cardiac output, cardiac index, stroke volume rise exponentially, and that can lead to a hyperdynamic circulation. Patient will have a high lactate because of the hyperthermia. Patient will have a hyperglycemia because of the hyperthermia, and patient will also have a hypokalemia because of the forced diuresis happening during the HIPEC phase. In the reconstruction phase, this hyperdynamic circulation continued for up to 24 to 48 hours postoperatively, and it will settle slowly over next 1 to 2 days. So like if I talk about this H0 phase, so H0 phase, I mentioned that in this phase, we actually prepared the patients for HIPEC. So it is start around 1 hour prior to the HIPEC. So we do some passive hypothermia. We do not cool the patient at that time, but we just stop the warming devices so that patient can have a reasonably low temperature to start when we start the HIPEC. And for this time, we arrange the like cold fluid. We like calculate this body surface area for giving the chemotherapy, because chemotherapy is always given on the based on the BSA. And we also like give this protective clothing and the mask to all the OT staff. We must prepare this hyperthermic solution. So the hyperthermic, I already told you about all chemotherapy we use. And for that, we need around 1.5 to 3 liter of the carrier solution. And this peritoneal dialysis, the solution is considered the most commonly used and the best solution to give the chemotherapy, because all these other solutions, they have a problem of either hyperglycemia or some other issues. In the H1 and H3 phase, is this full HIPEC phase. So your temperature rises exponentially from start of HIPEC up to H1 phase, and then it become plateau up to H2 phase. So in this, like we give the infusion at 41 to 43 second day. We give the gold active fluid therapy. The temperature control can be done by the infusion of either cold salines or the cold crystalloids, and giving like putting the cold ice packs over neck and the vein, and we can also like cool with the cold air blankets. So the goal is to keep the like this body temperature below 38 degree, any case below 39 degree. And but if the temperature goes above 39, then we can ask the perfusionist to decrease the temperature of the perfusate so that we do not harm the patient. Yeah. So this is the pump where you will see this video screen. This is the roller pump, and this is the inflow, and this is the outflow, and this is the blood like reservoir and all these things. So this is just like a cardiopulmonary bypass circuit. So there will be an inflow and outflow, and there will be a temperature probes of inflow and outflow also. So you will have the 4 type of the temperature on the screen. So this is the HIPEC this machine, and at 4 temperature like. So this is the machine. Okay. So about the unit output goal is also important, because so in the CRS phase, we always maintain the unit output of around 0.5 ml or more than 0.5 ml per hour, just like any major abdominal surgery. But in HIPEC phase, we maintain a little bit of higher unit output, around 2 ml per kg per hour. But if we are giving a cisplatin chemotherapy into the abdomen, and that have a high chance of developing the acute kidney injury post-operatively. In that case, we can even maintain a high output up to 4 ml per kg per hour. And we can also give some diuretics like mannitol or Lasix if required, but mostly it is not required. And in the reconstructive phase, and then post-op phase, it is again just like any other surgery. We can 0.5 to 1 ml per kg per hour. We maintain the urine output. So, if we are giving this cisplatin chemotherapy, there are some agent like, and there are high chances of like patient developing AKI in the post-op period. So there are some like agent which can be given to prevent the AKI. So this is one of the study they mentioned this using the sodium thiosulfate for the production of the renal impairment after HIPEC with cisplatin. So they have given the sodium thiosulfate 10%, 9 gram per square meter, 200 ml just before starting the HIPEC, and after the HIPEC, they given the continued infusion of sodium thiosulfate 12 gram per square meter on 1 liter in 6 hours. So this is a prospective before and after study. So in the control period, they have like included 35 patients, and during this treatment period, they included 38 patients, and they came out with the result that in the control period, there was a incidence of 31% of AKI versus 0% AKI into the study period. So they conclude that the sodium thiosulfate is effective for reducing the renal toxicity after the cisplatin HIPEC, but this is not an RCT, so we should have a RCT to prove this hypothesis, but it's having some role in the period. So in the post-operative period, so this continuation of all this management, your cardiac output, all this you can continue to manage in the post-op period. Patients should be like electively ventilated or extubated on table. That depend on how bad lungs or the severe cardiopulmonary disease if you have. And the main important thing that if the patient has undergone this diaphragmatic stripping, in that case we always like do post-operative ventilation. But if there is no diaphragm stripping, we can still try to extubate the patient. And also we can like take into account of what about the blood loss is there. So if there's a massive blood loss, so we can give a like post-op ventilation. If the patient is hemodynamic unstable and having a very high vessel pressure use, then we can also ventilate the patient. Otherwise, we can also extubate on the table. So mostly we will be able to extubate around 25% patient, not more than 25% patient. We do not extubate on table. And if you when we extubate in the post-op period, you can give either elective NIV or the high flow nasal cannula to prevent some atelectasis in the post-op period. And it should always give a good analgesia. So if we have the thoracic abdominal analgesia, it's well and good. If you don't have, then you can use other modalities of analgesia and maintain a good urine output of around 1 ml or more than 1 ml per kg per hour, and that depends on what chemotherapy the patient had during the HIPEC. And we should always maintain the strict aseptic precautions with handling of all these lines and with the due care. If the patient had undergone this diaphragmatic stripping and a total pyetonectomy, these patients require a lot of fluid in the post-op period. And if you do not replace those patients, the fluid, the patient may go into the hypovolemia, and patient may have a problem. So these patients are mostly either large pseudomyxoma pyetoni or malignant peritoneal mesothelioma. So I have observed that these patients will require a lot of fluid, maybe sometime around 300 ml or 400 ml per hour fluid in the post-op period for at least first 24 hours, because they lose fluid from the drain, because your abdomen is very like angry looking and is a loss from the drain and like some distraction all over. So we must like replace the fluid properly in this type of patients. We must also order all this lab investigation and some electrolytes and parameter in the post-op period, at least for next 48 hours. And blood gas and the arterial lactate should measure in the post-op period. So also encourage the patient or some like physiotherapist for the intended spirometry and all that, and we should start the feeding patient early. Or the complications, so intraoperatively complications are either major blood loss or hemodynamic instability, and the post-op period it may be either surgical complication or non-surgical complications. Surgical complications are normally like either leak or some all-purpose abscess or infections, and the non-surgical complications are either pneumonia or some like neutropenia because of the chemotherapy. The other serious complications are like AKI if they're giving some like nephrotoxic chemotherapy. Hyperammonemia we observed in 3 patients in our like hospital. So the cause is still not like we don't know the cause, because all the liver were normal the day before and all these things. So hyperammonemia we observed in 3 patients, and 2 out of those 3 patients died after the HIPEC. And sometimes patient may develop in the rebound hypothermia. So rebound hypothermia patient develop like if you are like your temperature was too high during the HIPEC phase, and then you do not start the warming devices again after HIPEC phase, and then the patient remain in the OT for another 1-2 hours for all the clauses and all these things, and the patient ultimately will lead to the hypothermia. If the delta temperature means the delta means that minimum temperature when you start the HIPEC and the maximum temperature HIPEC, if the delta temperature is high, then you have a more chances of developing the rebound hypothermia also. Some recent advances, like if the patient is having a big disease in the abdomen and that is not really amenable to the surgery, in that case they can give some precise intraperitoneal aerosol chemotherapy. So that is called the HIPEC. So this HIPEC is mainly a palliative procedure where we just do this staging laparoscopy, and then they do some precise chemotherapy inside the abdomen for around 30 minutes. So they can be staged. So there may be 1, 2, 3, 4, 5 cycles of HIPEC, and in some cases, after the HIPEC, the patient may undergo surgery if the patient responds well. Another is the HITEC is the hyperthermic intraoperative thoraco-abdominal chemotherapy, especially like in patient with the pseudomyxoma peritoni, where there is some disease is like spread to the pleura. In that case, while like abdomen is open, so they open the diaphragm and the disease is removed from the pleura, and while the so while keeping this abdomen and the diaphragm open, they give this HIPEC phase and this fluid, so that fluid also go into the pleural cavity, and then so this is they can do this in thoraco-abdominal chemotherapy. Others, like we can also give like HIPEC plus or like the bidirectional chemotherapy, where you give the HIPEC also and we give the intravenous this chemotherapy also. In some case, they give this neoadjuvant like HIPEC. They can also do some prophylactic HIPEC, even if there is no peritoneal disease, but the cytology is positive for the some cancer cells after the stomach or during the staging lab of the stomach cancers. So in that case, they do a prophylactic HIPEC to have a good prognosis. And if the like some cases your HIPEC is not really like possible in intra periods, then in that case they can do the early postoperative intraperitoneal chemotherapy, that is called the EPIC. And in some thoracic cancers only, like a thymoma or like after like this extrapleural pneumonectomy, they can do this HITHOC or the hyperthermic thoracic chemotherapy. But this HITHOC is really a very morbid procedure, and patient the outcome is not really sure. So the take-home message of this talk is that this peritoneal carcinomatosis is not a death sentence, and we should be ready to manage a high-risk surgery and a high-risk perioperative period. A proper preoperative evaluation and optimization is mandatory. We should be ready to manage the hemorrhagic shock, and the goal-directed fluid therapy, the adequate hemodynamic, and the temperature monitoring is required. And adequate urine output, especially during the HIPEC, should be maintained, and a proper post-operative care is always in favor of the patient. Thank you very much.
Thank you, Dr. Sohan, for a very nice summary of the management of HIPEC, the CRS and HIPEC. So, are there any questions in the chat box or in the Q&A? Okay, so while people are hunting for questions, Sohan, if I may ask you.
Yes, sir.
So, what do you think is the most challenging part of this entire procedure? The CRS procedure, is one where there's maybe a lot of bleeding and a lot of fluid shifts and a very prolonged procedure.
Yes, sir.
Is that very challenging? Or is the HIPEC, which is a relatively short procedure, but which produces profound metabolic and physiological changes? So what sort of challenges are there in these two sort of sections of the surgery?
So in this procedure, like this CRS is, I'll say it is more challenging than the HIPEC, because if your CRS part is really good and like you have a very like small disease, like only into the and so in the pelvic part only the disease is there, or only around the stomach and some part of the peritoneum involved. So in that case, like your CRS is done very fast and there is no hardly any blood loss, and so in that case there will be no big challenge for this management. But the patient with the like this big pseudomaxima bedni or this like mesothelioma, they have a big disease and the resection is like very large resection, and they need the portal resection, bilateral, the diaphragmatic like stripping is required, and like some colon or some other organ section is required. So that is, I think, more challenging than managing the HIPEC. During HIPEC, we have to manage the temperature, but that temperature can be managed with the fluid. So in my view, sir, the CRS is more challenging than HIPEC.
Okay. So, but I think the CRS is something which people who are doing major surgery will be sort of equipped to handle, the blood loss, etc.
Yes, sir.
But the challenge, I think, is to manage the temperature changes which
Yes,
occur
sir.
between CRS and the HIPEC and the post-HIPEC sort of phase.
Yes, sir.
And that, okay. So that's
Post-HIPEC period is also very important. So at least that first 24 hours after this pseudomaxima patina is really very challenging to manage, sir.
right. So there are a couple of questions. One is asked about the role of ionized calcium in this procedure. When should you do it, and how often should you do it, and how much do you do it?
So this calcium management we like do based upon the like our calcium level in the ABGs. So mostly like if you are giving too much blood, then your obviously your calcium will be low, and then we'll need to do the correction. And in
Right.
anyway, in a like big surgery, around 10-12 surgery, the patient may have some kind of hypocalcemia, and we may need to give calcium. But it always depend on the like what values you have with you.
There's another question about albumin. So when you said you should give albumin, you probably meant 4% or 5% albumin. But there's also a question: is there any recommendation for the use of 20% albumin during or after surgery?
Yeah. So there is albumin level. So albumin we mostly give as a colloid. No, hardly we give as
4% albumin.
20%. Yes. So that 4% we give albumin as a colloid. So that is not to like to increase the level of albumin in the patient, but to give the colloid like a good colloid. And the 20% albumin, like if you have a really like low albumin level, and despite your best this prehabilitation and your nutritional improvement, patient is still having a low albumin. In that case, I think we can give the 20% albumin to the patient intra-op and also in the post-op period.
So along those same lines, these patients have had a massive resection and anastomosis and all this handling and the hyperthermia during the surgery. What is the guideline, or what is the thing for nutrition in the post-op period? Do they go on enteral? When do they go, or do they just go on parenteral nutrition, or what are the recommendations regarding nutrition of these patients?
So in the post-op period, if the abdomen is okay, mostly these patients they started this enteral nutrition on the day 2 in our hospital. But if the abdomen is not settled and like patient is like if it's not coming out of ventilator, then we definitely start this TPN, and there's a very low threshold of starting TPN, and sometimes we can give this combined also, like give some of the enteral, some parenteral. So that depends on patient to patient, like how the patient is behaving in the post-op period.
So there's again a question on what type of fluid do you use in your practice?
During HIPEC or intra or post-op period?
Both. Mainly intra-op and I guess a little bit post-op.
Yeah. intra, we use this this ringal lactate we use. We normally use this colloid as this albumin as a colloid the 4%. And in the post-op period, we like this all. Also, we use this only. We did not really use those like this melatonin acetate based balanced solution, but we use the ringal lactate only, sir.
And you mentioned that you use the flow track for cardiac output monitoring. Are there any other monitors that can be used or that you have?
Yes, sir. So there are so many type of monitor we can use, and they can use this flow track also. We can use like SPI monitoring. We can also use the PICO, LIDCO, whatever like monitor you have in your OT or ICU. They can use the type of cardiac monitoring.
You say it is mandatory to use cardiac output monitoring, or if you don't have it, it's optional?
So it is not mandatory, but like I said, that this arterial line monitoring of the invasive BP is mandatory. With that, we can also use the PPV as a goal. So this cardiac monitoring is not mandatory, but it is desirable to use if the patient is having a big abdominal disease.
Okay. So I just had a question regarding the cardiac output.
Yes,
Now,
sir.
there is this concept of augmented renal clearance. So when you have a very high cardiac output,
Yes, sir.
and like you mentioned that the urine output anyway increases to 2 ml per kilo on its own, more or less.
Yes, sir.
And that is probably because of the vasodilatation and the high cardiac output.
Yes, sir.
So, of course, it produces a high urine output. But does it result in increased clearance of some of our drugs? So, for example, a hospitalaxin, so you need more frequent dosing. What about the antibiotics that you may have used? Do you need to top up the antibiotics more frequently so that, the prophylactic antibiotics that you give and some such considerations?
Yes, sir. So theoretically, yes, because sir, because if we are having this augmented renal clearance because of the hyperthermic circulation, then theoretically maybe we must be like giving like more frequent dosing. If the dosing is BD, then we may need to give the TDS also in some cases. But I'm not really sure like because we are not giving them based on that, sir. We are not practicing this in hospital.
So now you mentioned hyperammonemia.
Yes,
and
sir.
it was in patients. And
Mm.
so what prompted you to look for ammonia, to do the ammonia levels? What are the signs, symptoms, and the patients who developed this complication?
So the patients were like they were not coming out of the place like they were like so that the GCS level was going into the bed and all this. So ultimately, because I'm doing all other tests, they were coming normal. And the only like we have not done was the ammonia, and then we sent the ammonia, and that ammonia came around 1200 in one patient and 650 in the other patient. We did the CT MR also in this patient, and they were also not really good sign of any improvement in the patient. So no other like so it was like diagnosis of exclusion, and then we like did this ammonia, and then we came to the final diagnosis.
And when you said they were unconscious and not waking up, this is in the immediate post-op period, or they got discharged, or they woke up and then they started having this complication?
So
what was the sort of time course of this?
The one patient she developed these symptoms after 2-3 days, but sir, like another 2 patients they never woke up, or they just woke up for like few minutes only, I think. But the one patient she developed these symptoms after 3 days.
Okay. So basically, at any point in time, you think you are suggesting that if they develop CNS symptoms which cannot be explained by usual sort of things, it might be worthwhile to just check the ammonia.
Yes, sir.
Right. And I guess if the ammonia is very high, then they will need dialysis or CRRT or something to bring the ammonia levels down.
And so in one patient recently, there was like the enzymes and this bilirubin became 13. One patient.
Right.
next day the bilirubin became the 13. So we did all this comb test and everything, liver, UAG and everything, but everything was normal. And then that in the uh, day after of the surgery, that again become and it came down, and on fourth day it became normal. So I don't know, and I didn't understood. I understood what happened to the patient. Whether
Yeah, it's a bit of an enigma.
Sorry?
So, okay, so we'll leave the ammonia because I don't think we've understood what happens with ammonia. If anyone has any experience with hyperammonemia, we'll be more than happy to hear your experiences about hyperammonemia after this surgery or any other kind of.
I just wanted to ask Sohan, what was the disease in all these patients? Was it a particular disease process which?
No, so two were like CA ovary and one was pseudomyxoma.
Okay, and was the dissection very extensive or anything of that sort?
No, in the pseudomyxoma, the surgery was around 14 hours, but that other two patients, they were around 6-7 hours surgery. So I think, so I published that also into our this Indian Journal of Critical Medicine, in that in journal, that report.
So you mentioned, Son, that the INR may be deranged, right, after hyperthermic chemotherapy. Yes. So the question is, if the INR is deranged, should you treat the INR, I mean, either vitamin K or fresh frozen plasma? If so, at what threshold? Or if the patient is not bleeding, then should you be treating the high INR? Because you have to want to, and also there's a question of DVT prophylaxis in patients after major surgery like this. But if the INR is prolonged, what do you do about the DVT prophylaxis?
So like so so in this patient, the normal post-op INR is normally around 1.6, 1.5. They like it remains in that range. So we normally do not just treat with the FFP and all these things unless we want to remove the epidural catheter, all these things. Otherwise, we normally do not treat with FFP and all this, but we can like give some of the vitamin K and all that. About the DVT prophylaxis, so even if the INR is high, your patient may develop DVT. So that I think DVT and so this DVT prophylaxis, I think, should be given even if the like INR is around 1.6, 1.7, right, sir?
Yeah. Okay. So basically, you're not suggesting any use of prophylactic FFP
yes,
or anything. Unless the patient is bleeding, then I guess you have to take care of the INR. Okay. So any other questions anyone wants to ask? I think I've asked almost all the questions at Q&A. Now, okay. So now here is a question: is are there times when HIPEC as planned, but it's not given then after the resection? So I guess in that case, there's nothing much to be done, right? It's like a standard major excision of some sort. So like there were 2-3 times when we did not do this HIPEC after the CRS phase because that patient was not really stable to give HIPEC. So in one case, they injured the IVC and there was a massive blood loss, and then the patient become patient was on the very high dose of vasopressor. In one patient, I given the this noradrenaline along with the vasopressor into the OT. So in that case, we did the HIPEC after 2 days on a Sunday. And then so in that case we can like defer the HIPEC. Otherwise we can give HIPEC if the patient is on a minimal or low dose of the like HIPEC. We can on NORAD we can still give the HIPEC, no issues. And we also monitor the coagulation status into the period. So I mentioned that we send this all lab investigation like CBC and coagulation, and in some cases we also do some tag monitoring intraoperatively to see the coagulation status. If you want to like if there is a massive blood loss and we are given so much blood, then in that case we monitor this coagulation status intraoperatively also. So that is coagulation monitoring in case of massive blood loss. Yes, but sir. Just because the patient has undergone hyperthermic intraperitoneal chemotherapy, do you monitor the coagulation after that phase, or?
So normally, so we just measure once after in the post-op period. If that is normal, then we do not need to repeat it. Yeah, but in the post-op day one, the we like ask for at least one report.
Okay.
Hmm.
So you will monitor after the hypothermic phase and then on post-op day one.
No, sir, not hyperthermic, but in the
Not routinely, yeah.
not routinely, because if we are done in the intra period, we don't monitor after the HIPEC phase, and then we can call for the coagulation test next day in the POD one. Yeah.
Okay. Okay. Great. So, are there any more questions for Dr. Sohan? Anyone wants to ask any
So the one
question?
Are there any cases that have stayed with you? Sir, are there any cases that have stayed with you, Manin sir?
Yeah, so is there any cases that have stayed? Anything which has made a lasting impact on you?
Okay,
And
so
what was the major learning point from those cases?
I like two patients I mentioned about the rebound with hypothermia. One patient was the Bengali actress, and she that I remember her name also, and she was and she undergone this pseudomeximum PET9, massive surgery, massive blood loss, and the patient was shifted into the recovery at 2 o'clock in the night with the major blood loss and everything. The patient was there, and the patient at 5:30 I got a call. The patient got arrested in the recovery room. So and that patient we did the CPR for 20 minutes. The patient was there was some 20-minute ROC time was there, but patient after 20 minutes patient become fine, and then patient extubated 2 days later, and then she went home. She again came for the HIPEC after the 3 years. Now she's okay. One patient, then again the two patient I mentioned that is hypothermia. So they develop cardiac arrest in the post-op period after major surgery, and then both the patient are fine. So in that case, I sometimes think that hypothermia must have saved the patient. I don't know.
Okay. So just a few questions about it seems that this is becoming more and more common, these operations, and you mentioned they're even going to do prophylactic HIPEC.
Yes, sir.
So after some artery colon or stomach resection, they might. So all of us, I think, have to get used to handling these sort of cases, especially the temperature management towards the end of the CRS and during the HIPEC and after the HIPEC.
Yes, sir.
And what are the outcomes of these surgeries in the different indications? For example, in pseudomyxoma, in colon cancer, or in gastric cancer, what are the sort of outcomes?
So the outcome wise, if I
the
say
oncological outcome, I'm asking you as a.
So the oncological outcome, I can say, if the patient is having a pseudomyxoma, so the pseudomyxoma patients are having a good outcome, and they have a very good 5-year survival after the surgery. One patient coming from Lucknow, we did this HIPEC this time, 3rd time, because of the pseudomyxoma, and every 2 years he was coming for the some disease recurrence, and they coming for the, so they have a good
but so on that means recurrence-free survival is not great.
Yeah, but they have that recurrence-free survival is not great, but they have the lifespan is good, 5 years survival is better.
Right.
So in that, and if you see the PCI load or the PCI, if you talk about the colorectal cancer, so with the PCI of less than 10 is okay, but more than 10 PCI in a colorectal cancer has a bad prognosis. So there is no big outcome with or without HIPEC. If you have PCI more than 10 in colorectal cancer, but less than 10 is they have better outcome. Stomach cancer, they also have a better outcome if the PCI is low. But in pseudomyxoma PCI cancer, they really don't look at the PCI, because even if the PCI is 39, they have a better outcome. So that's why they do in all cases of the pseudomyxoma.
For which cancer?
This is pseudomyxoma PET9.
Pseudomyxoma, the PCI is not very relevant, right?
Yes, sir. So that irrespective of any PCI, the pseudomixoma, they have a better outcome.
Right. Okay. So oncologically also it seems to be worth doing, and therefore I think we are going to see more and more surgeons
Yes, sir.
doing these procedures. And I guess they'll have to be done in good centers because they need a lot of very good intra-op care as well as post-op care. And some of these patients have had pretty stormy post-op courses, at least for a few days before they sort of settle down. That
Yes,
sort of
sir.
thing. So any arrhythmias and other cardiovascular complications you see in these patients?
Arrhythmia, not seen in any patient intraoperatively or postoperatively, but cardiovascular complications, we have not encountered any of these complications. I don't know if it's happening or not, but there was no serious arrhythmia or like other complications we had, other than some.
And I guess there might be a learning curve for all of us in this because, initially when we started doing, there were a large number of complications. Of late, touch wood, they seem to have sort of, at least the post-op complications seem to have tailed off quite significantly.
Yes, sir. So when we started this HIPEC in 2015, then surgeon used to say we want 400 ml urine output every 200 ml urine output every 10 minutes during the HIPEC phase. So it means in the if urine of 90 minutes, you must be having a 2 liter urine output only during the HIPEC phase. So we came from that 200 to now 2 ml per kg per hour.
Yeah. So I think sometimes doing too much is also a bit of a bad thing. Yeah. Okay. So what are the highest and lowest temperatures you've seen?
So in one of my patients, the temperature went up to 39.5. In that case, we stopped this HIPEC. First, we decreased the temperature, but that despite decreasing temperature, the temperature was not coming down, and so we stopped the HIPEC. In the one other patient, so actually the temperature was very high, and then that resident, I was just out for washroom, and he came. Temperature is very high. We want to stop. I just let me come. So I gone inside, and then I saw that the temperature was really 39.5. And then I find out that the temperature probe, they were putting the esophageal, and temperature was in the stomach. So that because we are giving the fluid in the abdomen, and the stomach is there, and the temperature above in the stomach. So we pulled out the temperature probe, and then the temperature become normal. So that is also one of the things we can may have.
Yeah, that's a great practical point. Make sure the temperature probe is properly positioned in the esophagus, right, and doesn't go all the way down. Sometimes you just tend to push the probe without checking the lens. So you need to make sure it's nowhere near the stomach, especially during in these sort of procedures. Okay. So someone asked about hyperbilirubinemia. Dr. Meenal Agarwal says they see it quite frequently in post-op phase, and liver enzymes may also increase. Why do you think this happens, or is it because of handling of the liver, or is it part of the inflammatory reaction, or is it part of blood transfusion, etc., etc.?
So this is some kind of this hyperbilirubinemia we may see because if we are doing this portal resection and everything, and if there is a long surgery, if there is some amount of hypotension intraoperatively because of the major blood loss, we may found some time of the. But I mentioned that recently my patient having the bilirubin of 13. Only one patient I've seen with the 13 bilirubin next day after the surgery. So in that case, we have done everything like this cum test, and we even that cross match blood again in the blood bank, but there was no other cause we found for that. So porta surgery and all this, we may have some kind of hypovolemia, but not always, and maybe I don't.
So another question about extubation is the decision to extubate on table or not to extubate linked to the duration of the procedure, or basically what are your parameters which make you extubate or not extubate the patient until.
Yeah, so I mentioned that we do not extubate if the patient had undergone this diaphragmatic stripping. One thing is that is the most common indication of giving a post-op ventilation. And second, if the patient is hemodynamically unstable, massive blood loss, either if the patient undergoes one blood loss, and also like a long duration surgery are also one of the indications, like the patient have a more than 12-hour surgery. I think we can give like some period of the post-op ventilation. That is also fine.
I don't think there are any more questions. So Dr. Sohan, I want to thank you for your very lucid presentation and for also tackling all the questions and all the queries that many people had, including myself, on this topic of CRS HIPEC. So I think if there are no more questions, we'll hand over to Dr. Anjali.
Thank you, sir.
Thank you, sir. Thank you, Sohan. It was a very productive discussion, and I think there were very pertinent questions that came up from the audience as well. So I would like to thank the audience for their participation as well. And with this, I think we'll come to an end to this session. We look forward to the next one. Thank you, Ankita. Good evening, Ankita. We can end the session.
Yes, ma'am. Thank you so much. Thank you so much, everyone, for sharing your valuable insights. And we are more than grateful to have you over here. So with all your permission, we'll conclude the session over here.
Thank you.
Okay, thank you. Thank you.